Good morning and good afternoon, depending on where you are. Happy to have everyone here today for our Wednesday webinar. Today's topic, Financial Advantage, 5 Factors for Success. We're excited about having Nancy Babbitt with us again today. Nancy is a practice transformist, nationally recognized expert and speaker with far-reaching expertise in medical practice operations, governance, and technology. She's passionate about helping practices of all sizes, advocating for physician and practice administrators, helping them provide quality health care in an efficient manner. Nancy is a past chair of the Medical Group Management Association, National Board of Directors, and founding member of the National American Academy of Pediatrics, Pediatric Practice Managers Association. She's a fellow and board certified by the American College of Medical Practice Executives. So with that, let me hand it over to Nancy. Thank you.
Thank you, Brent, and welcome everyone. It's a pleasure to be with you here today. It's nice to be back, and today we're going to talk about how you can get that financial advantage. And when I managed a practice for over 30 years, vascular surgery, pediatrics, and now been consulting for 6 years, I've seen 5 areas that I think really influence your practice. So that's what we're going to talk about today. And I hope you don't mind that I keep my webcam on. You can look at my mug as we go through this, but I think it keeps you more engaged, and I'm a real talker, and I like to talk with my hands. So we'll get moving today. Oh, and by the way, there's a GoToMeeting box on the right-hand side of your screen, and there's a box in there that you can click if you have questions. So we encourage you to ask questions as we go along today, and I'm going to ask you for a little input on a couple of the slides also. I will be giving these handouts to Brent to share with everyone that's registered for the presentation. So I have some tools that will be helpful for you, and you will get a copy of the handouts. So the 5 areas that we're going to discuss today are workflow, technology, revenue cycle, return on investment, ROI, and culture. But before we get started, let's talk just a little bit about healthcare spending trends in the United States. This is a big graph. That blue line on the top is the United States, and then many other countries underneath. And this graph shows our per capita total expenditures on health at an average exchange rate. So it kind of compares us with many other countries in the world and how much we spend per person, per capita on, on healthcare in the United States. We spend a lot more, trillions and trillions and trillions of dollars on our healthcare. Now, how can we, in our little old practice, affect this? Well, I'm a big believer that we need to have influence on how we wisely spend these healthcare dollars. So when we talk about financial success and financial advantage, I like to look at it a little bit beyond just our practice and how we can really make a change, not only in our own practice on patient care and spending, but how it could affect our whole economy. As we know, it's a large part of our economy in the United States. The other thing that we know is we have a really lofty goal out there. As our payment and reimbursement is reformed, going from volume, where we get paid fee for service, so every time a patient comes in or we perform a procedure, we get a payment. We're shifting that to get paid based on value. And a lot of the value conversation and programs have come out of this quadruple aim. Now, when the aim first came out, there were 3 areas. It was the triple aim. We wanted to improve care, we wanted to lower cost, and we wanted to improve patient satisfaction with the system. We said, wait a minute, what about the providers? What about the staff? What about those employees out there every day working hard in healthcare? So they changed it to the quadruple aim, and they added to make providers and of healthcare satisfied also. So as we go through the presentation today, I want you to think a little bit outside the box. I know you're busy. I know you have a lot of crises you're trying to put out. I have a client that, believe it or not, was dealing with sewer flies the other day. Sewer flies. Who knew there was such a thing? But apparently in between the ceiling of their suite and the suite above them, there was some type of an issue, and these flies got in there, and really it became a major issue. So whether it's your phone system or some type of pest control, I know you have a lot going on every day, but I hope that you'll take 1 or 2 things out of this presentation today that you can take back and implement into your practice. So a little funny before we get started, having that serious counseling with your employee. I want you to find a bold and innovative way to do everything exactly the same way it's been done for 25 years, right? Because nobody likes change. So the first area we're going to talk about is workflow. And so many times when I talk to practices about workflow, they kind of just glaze over. And yeah, sometimes I do get that comment. We've been doing it this way for blank number of years and it's worked fine. So why should we change things? So I'm going to challenge you a little bit on that today because this can really make a difference in your bottom line. And what I've found is so many times in healthcare, we have tunnel vision, and it helps us to look outside of healthcare and compare what maybe large corporations that have a larger budget or that can go to Japan and study the way that they do things and their workflow process and just things that we may not have access to. So I'm going to share that with you today. And I have a tool that goes into more detail. I do have a couple slides that we're going to talk about that, excuse me just a minute, I got to get my control panel in the right place. There we go. Okay. I know I shouldn't be saying on my presentations. There we go. I have to say when I'm not concentrating. It's hard to do two things at once, isn't it? So the first thing we're going to talk about under workflow is unnecessary movement. And in corporate America, they would call it their product. Where does their product go? What can they do more efficiently? Well, our product could be a patient, a specimen, paper, how many documents are floating around our office, and then also materials. So if we just think about where does a patient go in our office? I recently went with my father. Now, he had broken his back. He's 90 years old. He's in a walker. He's got a brace on. It's hard for him to move around. They bring him in this really narrow hall where they had put a provider who's standing out at a little desk and keying that's standing in the hallway, take him down to the very end of the hallway where he has to leave his walker, get up on a scale, do his height and weight. Then he has to get back down, figure out how to turn his walker around in this narrow hallway and go all the way back, all the way up to exam room 1, which is where they first brought him in. So just thinking, and I know we have limitations in our facilities, but ask your staff, ask your patients, do a focus group. Are there just little things that maybe you could do to make that patient flow a little bit different, a little bit more efficient? Do you have departments in your office where maybe they're going for lab or x-ray and having to walk? All of those things can be so important in the workflow in that unnecessary movement. And you're thinking, well, Nancy, how can I save money on this if the patient doesn't have to walk as far? Well, it can really help the patient experience. It can help that provider who has someone walking behind them when they're trying to key. How efficient are they? Just a lot of little things that add up that if you take the time to ask the staff and the people that are really doing it, they might be able to brainstorm and help you figure those things out. Have you ever followed a specimen through your office? I love to do what I call the paper chase. So there's a lot of paper floating around in our offices. I know technology and EHR were supposed to help us with that, right? Cut down on the paper. I found we order reams and reams of paper because it's great. We're printing out educational things for patients and sending it home with them, all kinds of things. But if you have paper floating around your office, do the paper chase. Follow that piece of paper around. See, where does it go? Why does it go there? Does it need to go there? Should it be closer? Is there something more efficient? And don't forget about your materials. I know we're all pretty good about stocking our exam rooms and making sure they're consistent. But if we asked our staff, what do you leave the exam room for? What do you need? What do you don't have in the lab that you're having to walk to a supply cabinet for? All of these extra steps and little things add up every day. And I can tell you, if corporate America is paying attention to it, we should too, because our number one expense in our practice usually is our staff and our personnel. The other thing that corporate America pays a big attention to when it comes to unnecessary movement are our team members. How much time are your team members spending searching for things? Maybe it's lab results. Maybe it's having to walk up somewhere and find something at the front desk. Whatever it is there a better way to use your technology to be more efficient? And yes, go again to them, ask the people that are using it. Facility limitations we can't do much about, but a common thing I find are just little things like printers. We don't want to spend the money to put extra printers around. Well, I'll find staff members, doctors, and clinicians that are in exam rooms that need to print a form or print something to the patient, and they're either having to walk to the lab or back up front to get that paper. Or sometimes worse, they tell the patient just to pick it up front, and then there's this huge stack of papers with everybody's medical records there, and it's up to a front desk person who's not clinical to sometimes sort it out and figure who gets what, which scares me when it comes to risk management, right? So take a look at those things, ask your staff, explain to them, we want you to be as efficient as possible. We don't want you to have any unnecessary movement. Even if it's 10 extra steps a day, why do we have to take those 10 extra steps? And what savings could we get out of that? The tool I'm going to share with you is called downtime. And you'll see on the left-hand side of your screen the word down spelled out vertically. And then next to each one is the area of waste. So this was a study that was done for a hospital system that's kind of been modified now for 8 waste and medical care delivery. And a lot of things will make sense to you. So I encourage you, if you have a little time, have someone in your practice that's into these kind of things that maybe you could delegate or form a committee, just to sit down one day at lunch and read through this document and say, wow, we've never thought about that. Some people would see the waiting one and they would think, oh, yeah, the waiting room time is important. But what if you have staff that's just sitting there waiting for the next event to occur? Many times in healthcare, it could be sitting in a physician or clinician's task box waiting for an answer to get back. You know, if we got the staff and the clinicians together, is there some way to expedite that process? Of course, we don't want anybody that's non-clinical making clinical decisions, but is there just a better workflow or a better way to get those answers instead of just always waiting for the next event? Can we cut down on retesting or processes that seem to be duplicative? So I encourage you to look at this one. The next slide is the second half of the word time, and it's spelled down on the left-hand side. And these were a couple of the areas that I hit in the 2 slides that we went through previously. But I'd also talk a little bit about inventory. I find so many times people think, oh, I've got my inventory under control, but what I find is actual hoarding. I don't know if you have any hoarders in your practice, but you might have somebody in billing that's hoarding highlighters. I don't know why billers like highlighters, but I always find a lot of highlighters with billers. But more importantly, in our medical supplies, a lot of times we have clinical staff that's overseeing that, and their way of inventory control is, oh, my shelf is full. Well, so many of our medical suppliers now today give us the technology with barcodes and our utilization habits or things that they can track for us. And you can really use the technology that's out there to track your inventory control and do reordering and use that technology. And sometimes clinicians are a little bit intimidated by that. And they're like, Nancy, I'm a nurse. I don't want to use a barcode system. I don't even know what he's talking about. So that you may need to help them or get someone that is comfortable with technology. But I can tell you can save a lot of money on that inventory control and not have things sitting on your shelf that you're not going to use for 6 months. Because we all know most of our supplies now we can get in a day or 2 from these great medical supply companies. So I really want you to think about workflow and how it affects the practice and how maybe there's some savings there or some efficiencies or improvements even in patient care, timeliness, things like that will help the staff and the care in your practice. I wanted to share with you a real live example of some workflow changes that came about by talking to staff. I interviewed an associate of mine, Pat Mullins, and she works at Infectious Disease Physicians in Annandale, Virginia, and they've had a great affiliation success story. They went out and talked to their staff and said, what can we do? How can we improve our care setting, the efficiencies? They have patients in what they call the 360-degree care setting. So these infectious disease patients many times are chronically ill and family or caregivers are assisting them with their care. They could be at home, they could be in the hospital, they could be in a nursing home, or they could be receiving home health care. And what they decided to do was the first thing is no matter where the care setting, this patient always has the same physician covering the same patient. So it doesn't matter where that patient is, home, hospital, wherever, it's the same physician covering that same patient. They decided to go first with a pilot program with a home health agency because that seemed to be the biggest need from the staff on lack of communication or things falling through the cracks or patient getting discharged from inpatient, going to the nursing home. The nursing home wouldn't get the orders updated right away. Those kind of things were happening. So that was where they really wanted to target. They started small. It took a lot of communication. It took Pat getting hospital administration, home health, her providers and clinicians all in a room together and starting to collaborate and start small, start with little things and build. So they did phase 1, phase 2, phase 3, phase 4. Bottom line, after phase 4, they lowered their readmission rate. And not only did they lower the readmission rate, they lowered their 72-hour readmission rate to zero. Zero. Do you know what a great success story that is, not only for the practice and the clinicians and just healthcare and cost, but think about those patients and the caregivers, that nothing fell through the cracks and they didn't have any readmissions in a short period of time. They were also able to reduce their antibiotic costs by 6.5%. And oh, by the way, saw a nice return on their investment, a 20% increase through shared savings. And it came about through collaboration. They actually put a full-time nurse practitioner in these other settings. So when the patient's discharged from the hospital and goes to the nursing home, there's a nurse practitioner at each location, and they shared that cost. But they also shared the savings that they were able to gain by that, by having these things working together and everybody communicating and affiliating and aligning. So really great success story I wanted to share with you. Another little funny, hey, it's simple. My nurse blindfolds me, I spin around a few times, and then I try to attach your tail. Hope it works, Mr. Donkey. So next we've got to talk about technology. And technology touches all of these areas, but there's some really important things within technology that I want to bring to your attention. But you'll hear about it in a lot of the other areas that I talk about too. So to start with, let's just talk about the electronic health record. I know we have them. Some love them, some hate them, but there's simple things that just never get done. What I find is when we implement a system, we kind of have that 80-20 rule. 80% of the things that are consistent or that we do routinely or daily, yeah, we can get those up and going when we go live because we have to have them. We need them, right? And then there's that 20% that you're like, yeah, I'll get to that. We'll do that. We'll get the doctors involved. We'll do those tough templates. We'll do whatever it takes. But sometimes we have other things in life, like sewer flies, that we have to take care of, and we just don't get to those. So I want you to really think back about when you implemented your EHR and what haven't you got to that you thought you would. Some of the things that I see on a frequent basis that help your financial success and are critical are listed here on the slide. The first one we're going to talk about is linking codes. So many times I go in and I see clinical people and they're giving injections, whether it's vaccines or antibiotics is a great example, or sometimes a procedure. And these clinical staff, they're great. They fill out the template. That's important. They mark off the box. Yes, I gave the vaccine, the injection, whatever it was, but they don't know the billing rules. They don't always remember to bill an admin code or an injection code or whatever else we can bill with those primary procedures. And then they'll say to me, but Nancy, I have the best billers in the world. That's what they do. They check these. And I know, I get that. We have great billers and they do know what should go on a typical claim, especially things like this, that it's 100% of the time. If you did this procedure, you know you're going to bill that admin or that injection code. But we're human beings. We make mistakes. When I was managing a pediatric practice for 23 years, we implemented 2 EHRs. And before we implemented right after we implemented the first EHR, we wanted to get some proof of return on investment. So we did a study. We hired someone to come in, and she checked our paper charts and our paper super bills before the EHR implementation, and then after the EHR implementation, where we had linked codes and set a lot of time up on the billing end to really take advantage of the functionality in the EHR. And do you know about 18% of the time we missed billing a code? And we have great people doing great things, but we're human beings. We get busy, we get interrupted, and things happen. And you know what? We all work too hard to let 18% of our charges go out the door and not get billed. So those of you that are with TryRQ, they have Q Pro and Q Complete that can help you set up and link codes within their systems and smart technology. I would encourage you to reach out to them. If you're with another EHR vendor, check that functionality and see if you can link those billing codes for the staff. The second area I want to discuss is customizing templates. Again, we're so busy and overwhelmed when we implement and go live. It's easy just to choose those standard templates that are out there. I know with TryRQ, if it can be done in Word, they can put it in a template for you. So be sure to make it as easy as possible for our clinicians, right? They need this EHR to go as smooth as possible. The last thing we want them to do is just go into an open box and start keying in their visit, because that's what I see a lot of them do. If we don't take the time to customize their templates for them and make it easy for them to use, a lot of them just go and key it in, which, number one, how fast can they key and how accurate they are? And some of them have gotten very good, but how can we collect discrete data? We can't collect our quality reporting data. We can't do data mining. We can't do population health and be secure that we have good, accurate data if we're not putting it in the discrete field in the customized template that we need to. If they're just keying away verbiage, it's very hard to accurately compare that and do population health and have good statistics, good data. So I would encourage you to go back. You don't have to do it overnight. You could pick a template a week, a template a month, form a committee, whatever it is, but take time to look at those templates and really make it as easy as possible with as few clicks as possible for your providers. And then last but not least, under electronic health records, we have to touch on risk management. And customizing templates is a great one, because I see so many practices where they'll have 100 or more templates. And I'm like, oh my gosh, why do you have all these templates? Well, doctors keep adding them. They didn't like this checkup, or they didn't like this otitis media one, so they grabbed that one and pulled it in. Well, let's think about that and think back to workflow and think about risk management with patient care and what could fall through the cracks. If we're using a bunch of different templates, and maybe you have one provider, well, I always use this template, Nancy, and I always have the same nurse. Well, I kind of have to challenge you with that, because you don't always have the same nurse. That nurse goes on vacation. She has sick kids. Nowadays, we have people who work part-time. We have part-time physicians. We have extended hours. We have a lot of people supporting and working with a lot of different physicians. Every now and then, it might be one nurse, one provider. So think about that. If you're looking for a lab result or something very specific in a patient's chart, and you're used to working with this provider and these templates over here, but now you're with another provider and he's using 20 other templates that you're really not familiar with, how much time is it going to take you to find that data that you need? And oh, is it going to be there, and is it going to be accurate? I think we're much more likely to miss something. So please, please, please try to get group consensus with multiple providers and cut down on those templates, because that way if you do need to make a change or you want to go back and do something like linking codes, you don't have to go through 100 templates. You know, maybe you have 30 or 35. That would be a great number. The other thing that I see a lot with risk management, and it's a passion of mine with technology and EHR, so I can get on my soapbox, but one other thing I'll just point out in today's presentation is cloning and copying records. So many physicians request this. Now, if it's on the same patient, I'm a little bit okay with that, especially if they're chronically ill and you know, you're copying those chronically ill things over and adding to and updating and making sure that it's documented that you reviewed it and you've updated any necessary information, or maybe there were no updates. What really scares me is when I see people copying or cloning from one patient to another. So please, 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 I know these EHRs have that technology and have that functionality, but it's very scary. So talk to your providers about that, because financial success also means no malpractice cases. And EHRs, unfortunately, have so much data and can be so overwhelming, it can unfortunately get us into a situation where we can make a mistake. And that's the last thing I want to happen at your practice. So use that functionality that's good. Let your company help you implement that and do what's good. But be aware and be educated. And if you have providers that want to use some of the functionality that really might get them in a little bit of trouble, there's help out there. I know TriRQ could help you with that and why they probably would not be a best practice to use cloning or copying with the EHR. The other thing I want to talk about under technology is telehealth. Telehealth is really, I think, up and coming more in the future. Some practices are doing it and doing it very well. I don't know many that are yet, and it's something that providers are starting to talk about. We're trying to figure out the payment system. So we've had a few of those early adopters that have kind of led that way for us. And Medical Group Management Association, MGMA, just came out with a new electronic book called Telehealth Adoption and Best Practices. Now, if you happen to be a national MGMA member, it is free to national members. But for non-members, it's $79. So it has the best practices. They did surveys in 2017 of practices that are already using telehealth. There's information in there about billing practices and codes and carriers that might be paying for telehealth. So when you get to that point in the future, really reach out, because this is another layer of technology that I think goes over and above the EHR that you can add on. There's many companies, choices out there on who you use for the video conferencing and security and getting the electronic signature, that you can do this over the internet with the patient. So just a lot of little policies and procedures that I think this book could help you with when you're ready to tackle telehealth. Next, we're going to go into one of my favorites, revenue cycle. And if you joined us on the last Wednesday webinar in April on the clinic administrator sandwich, we got pretty detailed on some of these areas, but I have some more highlights that I'm going to touch on today on revenue cycle. But first, we have to talk about our family health coverage and our next little funny cartoon. Yeah, I understand the cat's your family, but no, insurance isn't going to cover it, at least not health insurance for people. There is dog and cat insurance out there, though, I think, through the vet that you can get. All right, so now's the interactive time. Those of you that are on the line, I want you to go to the GoToWebinar box on the side of your screen and open that question box, and I want you to tell me, who is your number one payer? So if you'll just key in that number one payer, whoever your number one payer is, I kind of want to get a feeling out there for who your payers are. We can talk about it. So if you'll do that for me and key that in, I'm going to go ahead and talk about the next 3 bullets, and then we'll come back to the number one payer before we leave this slide. So let's just touch on fee schedules quickly. Many practices I go into, they have not loaded their fee schedule in their practice management system. And I have to kind of get out my mommy finger on that one, because that is so important. And again, they'll tell me, but Nancy, my billers know. You can go ask my biller on a 99213 or whatever code you want, and they'll tell you what the reimbursement should be from each carrier. Wow, they've got a good memory, because if I even went and challenged them on just your top 20 codes, and you're probably billing 100 codes, but you have your top 20 that are your most volume, have the most volume, and you maybe have 18 contracts or 15 contracts or 12 contracts, they must be a savant to remember on 20 codes and 18 contracts what we're supposed to be getting paid. I mean, that's just a big challenge. I challenge you, load those fee schedules into your system. It takes time, but it's so well worth it. And it'll let you know, are you getting paid? You're working so hard to provide these services. Make sure you're getting every penny. I have found on little things that are not the big dollar items is where mistakes get made a lot. Changes get made in their system. Maybe they're shorting you 50 cents. But if you're doing 5,000 of those things a year and you're getting shorted 50 cents, it adds up. So please load your fee schedules. Let's talk about denials. I hope you're working to your denials. Did you know a large percentage of us, like somewhere around 60%, don't work our denials? And it's complicated. There's many different ways and many different areas in that revenue cycle and workflow on how you can do it. I'll talk to my clients and they'll say, well, we're working the edits that come back from the clearinghouse. Good. Some people do, some people don't, but that should be your first place, right? When you submit those claims, you work that error report with your clearinghouse. Typically, you'll have an error report within the EHR that you'll work first. Then you'll work the claim denials that come back from the clearinghouse. So you can get those turned around within a day or two. Then they'll tell me, oh, but Nancy, we work all our denials. We work the denials right away when they come back on the EOBs. When we're posting payments, if there's a denial in there, we work it. Like, that's great. You're getting it done right away. That's good. Well, what else do you do? Oh, we catch them all on the EOBs. Well, no, you really don't. All of our practice management systems have delinquent claims reports, outstanding AR, outstanding claims, whatever their terminology is for that report. Be running that. Look at your claims at 30 days, 60 days, 90 days, way before you get to that filing deadline at 90 days, and make sure that you've got someone working those claims, because they may not be coming back on an EOB if you file it to the wrong insurance company, for example. So you will find some claims that hang out there too. So make sure you're working those denials. And a lot of people don't follow up on that. They don't create accountability. They put a lot of emphasis in their revenue cycle on getting the charges in, getting the payments posted. And by the way, when you're posting payments, work those denials. I think it's a full-time person that's usually, the return is there. If you can get someone to work on those, that's a great, great area to get a little bit more financial success in your practice. And again, we work too hard to not collect that money. The other area that ties back to revenue cycle, believe it or not, is in our schedule and our no-shows. And we all know we want to fill up that schedule. We want to fill up that schedule because that's the way we really get over that little hump to get our profitability. We've got to come in every day, and we've got a pretty high fixed overhead in healthcare. We've got exam rooms and medical supplies and high payroll with expensive trained staff. And we need to make sure that we cover that just to get that back every day. And then if we get that schedule full, that's usually where we get that little bit of extra profit to make it through the day. So what are we doing with no-shows? No-shows, we need to have a policy. I'm really big on written policies and scripting. Going back to that clinic administrator sandwich presentation, I honed that in, script. I'm not born with all these skills. I don't necessarily know the greatest customer service language just off the top of my head to call someone up that didn't show for an appointment and say why, and maybe it's their second or third time they didn't show, and explain to them in nice customer service friendly terms, hey, we had this slot in the schedule for you. You didn't call to let us know. There's other patients out there that could have used that slot, and it sat empty. And I don't know if I go into the revenue thing, but just letting them know it sat empty. And having that policy, I know a lot of people, if they don't cancel within 24 or 48 hours, they charge them a fee. I don't know how many people, though, have a policy. Maybe if you have 3 or more no-shows, you discharge that patient. I really encourage you to think about something like that, because not only are they wasting time on your schedule, if they're not showing up 3 times in a row, are they a very compliant patient? Are you putting yourself at risk maybe for a malpractice situation in the future? So something to think. You can really turn those no-shows into dollars. Get that script, get that customer service going, practice, role play with staff, have someone act like the grumpy old man on the other end of the line. Well, I just couldn't get a ride to the doctor today, and have your staff role play with that, because that is money that you missed by that patient not coming in today. All right, I'm going to find my glasses and see if we have any answers here in the question box. If I can get it to open. Okay, we've got Medicare as an answer, Blue Cross, and Cigna. So that's the number 1 payers that people shared with us, and I appreciate you doing that. I'm going to challenge you. 9 times out of 10, when I'm going to practices nowadays, the number 1 payer is the patient. And I, post-op, had surgery on my wrist. I have a titanium plate now with 9 screws, the bionic wrist, $5,000 deductible right here. That's a large chunk of money. And we're seeing that so many times. And guess what? Back to our revenue cycle staff, our billers, a lot of us aren't born with those skills to call up patients and collect money. And what do? What's natural human behavior? We're going to work on what we're comfortable with. It's much easier to call up Blue Cross and talk to a representative about a claim that hasn't got paid, or go on their website. But to pick up the phone and call a patient and try to get them to pay a balance takes a special skill. Not everybody's comfortable with that. And I tend to find that if crises come up and somebody's out sick, or it's maternity leave, or whatever it is, guess what kind of gets pushed to the back burner? Collecting the patient balances. Used to be maybe it wasn't as big a deal, and maybe that's why we did it, because it wasn't as much money and we were going after the insurance money. But go look at your reports. You may not be thinking of a patient as a payer, but they are. And many times nowadays, they are your number one payer. One more funny. You're suffering from a serious medical condition called lousy insurance, right? None of us have ever had to deal with that or explain to patients why their insurance won't cover anything. All right, so we got two more areas to go through. Return on investment's number 4, so hang in with me. We're about 35 minutes in and moving along. I want to talk to you about getting lost in what I call the alphabet soup. And I know we're all dealing with macro and MIPS, or maybe it's patient-centered medical home or ACO, or I could have filled up this screen with other acronyms to just overwhelm us, but I thought I'd just start with this list. And what I want you to think about is another acronym, FEAR. And when I think about fear, I think false evidence appearing real. So fear, false evidence appearing real. And whether I go listen to a webinar or I go to a conference or my physicians are talking to another physician in the physician lounge about macro and we might lose 5% of our Medicare fee schedule and we got to do this and we got to do that, and they come back in the office and they're like, Nancy, we have to join this ACO. It's just, everybody's doing it and we don't want to get left out. It's easy just to fall into that fear and go ahead and do it, but I want you to think about the ROI. If you're going to join an ACO, are they going to be able to interface with your EHR and collect the data that they need for you to report? Are you going to have to hire a whole nother person? And maybe it's a nurse who understands all the clinical stuff to be able to report it in a different system in their format. Whatever that is, you need to know what that cost is going to be. You need to do the due diligence to keep that financial advantage, that financial success, to figure out, okay, ACO, if I'm going to join you and I'm going to have to jump through this hoop and that hoop and hire this person and do that, what's my extra reimbursement? How am I going to get reimbursed for this? How am I going to cover that extra overhead? Macro and MIPS, the same thing. I see people just jumping through hoops and spending money, and it's 5% of their fee, of their payer mix. So figure out before you get into something, what is going to be that return on the investment? And right now, it hits these other areas. I've talked about it a little bit in technology and other areas, but where I'm seeing a big leg is this alphabet soup. These new programs that are coming out, or a community getting together, whatever it is, it's usually good, but you want to know before you go in it. Do a spreadsheet, do your due diligence, and say, hey, where's my ROI? I got to have it. An example, when macro and MIPS came out, the government gave us a cost estimate. What is the burden on the eligible clinician to report just one category? And we all know there's 4 categories under MIPS, but just to report the one category of quality score. If you're reporting under an EHR submission mechanism, about $600, through a registry, about $700. So, that adds up. That you have 10 providers, that's $6,000-$7,000 a year just for one category. And that doesn't include any extra costs that you have to maybe get the staff involved or customize templates or whatever you need to do to get it to where that eligible clinician can click the box or track that quality score to report to CMS. So again, to be thinking, okay, is this worth the money? Do I need to worry about an extra 2% in my Medicare fee schedule 2 years from now? You might need to, but I want you to know what your costs are too. So before we move into culture, we got to have a little funny here. Perkins, we need to talk about your understanding of company culture. Well, duh. Culture is one of those words where I think people just kind of glaze over. They really don't know what it means. And then I get this pushback. I'm like, Nancy, well, how does culture affect my bottom line? Well, I can tell you, it definitely affects your bottom line. With leadership and a position of power and privilege comes accountability and responsibility. So if we think back to that quadruple aim, and how are we leading people? How are we communicating? Are we sharing with them some of the challenges out there in healthcare? and why when they see us coming, it's like, oh, Nancy, I see you coming again. You're asking me to click one more box in the EHR because Cigna has a new program and we have to submit more data. And oh, by the way, when I see you coming, Nancy, you never take anything away. It's just an extra click. So, rather than just going and asking them to do an extra click, would it be worth having a lunch meeting, sitting down and say, hey, we've signed up with a new program with Cigna. This is really important because now we can prove to Cigna our quality and what great care we take care of these patients with. So communicating and creating that accountability and creating that culture that they understand the practice. We're coming in every day and doing these clicks and this extra work, but we're doing it because in our heart it makes us satisfied. It makes us know that we're doing the most efficient, cost-effective, best care that we can for that patient. And oh, by the way, your staff and providers need to know that our reimbursement system is changing and that we're going from that volume model to that value model, so they understand how important this is, that we get paid for the value that we provide. And then we all have to have a mission statement when we talk about culture. So this one just cracked me up. Nobody's perfect. You're right. It's not much of a mission statement. So I wanted to share with you a real live example again of an associate of mine, Pat Richardson, who works at the Kootenai Care Network in Coeur d'Alene, Idaho, and how she successfully put together a clinically integrated network. And I know they throw those terms around a lot. This is not a super large system, but she explained to me the way that she kind of deals with the physician psyche, and I think it's brilliant. We have to sit back. I mean, if physicians hear one more time, we're changing from volume to value, I mean, some of them just want to puke. They just glaze over and go, well, what does that have to do with me? You're going to tell me how to do different billing codes. You have to really sit back and I think, explain it to them in words that they understand. So this is doing healthcare differently, doctor. This is not the way you were trained to come in and sit in front of your patient and take care of your patient. You're still going to do that, but now our responsibility has expanded. And even though you may not be actively seeing what's going on in this clinically integrated network, we need you to help us set up our systems so that we can easily get an x-ray in from another system, or we can share data with the next specialist that we're sending the patient on to, whatever it is. Great example is when I went in for my fractured wrist, drove myself to the emergency room, was on morphine, they did all these x-rays. Well, I didn't think to ask when I left to get a CD copy of my imaging that they had done. So 2 days later, I'm in Kaiser and going in to see the surgeon. They're like, did you bring the x-ray? And I'm like, well, I have this. They're like, no, we need the CD image. And, I had someone drive me there and the ER was in a different town. There's just no way that I needed it then that day because I'm seeing the surgeon and he's telling me, number one, am I having surgery? What's that? What all I needed. So yeah, they did another x-ray and I got to pay another $60 for that x-ray. So just these little things, if we can explain to the doctors how important this is and that it's really changing, it's thinking outside the box, how can we align to give the patient the best care in the most efficient way and save some of these excessive costs of duplication and other things in healthcare. Now, what Pat cautioned me is to start small, right? Because we all know physicians, they'll give us one chance to do it right. And if we don't do it right, they're not always real tolerant to do it a second time. So start small, do something small that you can really have some success with. She feels it's really important to go outside of just your network. So sometimes if you're in a system where you have employed physicians or a large group with employed physicians, it's easier within your network to get them to participate. But the joy that they really got out of this was going outside their healthcare system and taking the time to meet with community physicians, to explain it to them, to get their buy-in, to get them to understand. And by the way, they all agreed on a community-wide population health system. So another technology platform on top of their electronic health records that they could all communicate with to share this data. So pretty involved thing by the time they got to the end of it. But as she said, she started small. She created a lot of structure and details because if you're going to get those outside the network physicians involved in the community, You've got to build that trust and that rapport. And I think by having things in writing and really getting detailed so everybody knows what's happening, and we're not taking patients or changing referral patterns. This is just simply about exchanging data and doing what's best for the patient in the most efficient way. So I hope you enjoyed that success story and get you just thinking a little bit differently about how you can collaborate with other people and leaders in your community to really make a difference. As we close out today, one more funny. I said barium, not barium. And I know we feel like that. I know we feel like every day we've got so much to do, and you come in and you get a to-do list and you get pulled away and you don't get back to that. And here I am telling you to do more and more things under 5 different categories. But again, pick 1 or 2. Don't do all of these. Start small. Maybe just the one thing you do is share this webinar with people in your practice so they see what's going on out there in the world and some of the successes that other practices have had and what we've learned from corporate America and hospitals and things like that. And you can do this. It's just every day punch away at it a little bit more and try to find in your heart and in your providers' hearts and your staff hearts that satisfaction. What can you do? What can we brag on? What can we say? Wow, we gave great patient care today. We've helped our financial success, which of course is important because we can't make payroll and pay the bills. We won't be here to take care of the patients. But how can we do that? Get a little bit more financial success, make sure we make that profit so we're here, but also be proud of the patient care that we provide, be inspired to come in every day, retain and attract great providers and staff. All these things add up. Financial success can have such an important part. And even though I may not be able to make the decision on buying a population health system, I can have influence on these decisions. And I can have a lot of influence managing the practice and being a leader in the practice on the financial success by doing that due diligence and doing the research and going out there and saying, hey, this is the future. We need to be talking about strategic planning and where we go with this. And with that, I'm going to turn it back over to Brent and say thank you for your time today. Brent, I don't see any more questions, but I'll let you make that final decision, see if you got any on your side.
No, I don't see any questions either, Nancy. Thank you so much for your time and a lot of the insights that you've provided us and everybody else today. A couple of things. A lot of the insights and benefits Nancy has talked about in today's presentation can be implemented either through our Q Pro or Q Complete offerings. So please reach out to our support team or your Triarch territory manager to inquire how we might implement some of these things that Nancy has talked about today. We'll also be putting a copy of or replay of today's webinar on our website and YouTube site. Also, please sign up for next month's webinar on June 20th. And thank you, everybody, for your time. We really appreciate it and looking forward to seeing everybody next Wednesday, June 20th. Thank you.